So I had a practice. It was in the same vicinity. It was about 30 miles down the road. And after about 10 years, I got invited to come teach. So I went back to OU, and I'd be walking down the same hallways and the same classrooms and the same offices. But I'd come across these people, and I'd say, "Where'd you come from?" You get familiar with the background, but you don't even register the lapse of time. So I'm saying I feel very comfortable in the lab, but who are some of you people? Where'd you come from? I don't recognize you. Anyway, yeah, I was on faculty from 2001 to about, I think, 2012, I believe. Things blur together after a while. There is life after professional practice. I just already alluded to the fact that I had been at OU for a while in academia prior to coming here. And one of the reasons I got into academia at all anyway is related to our topic today. And our topic, it's not fully spelled out, but the facilitated oscillatory release theme or element in manual practice grew out of the work of Dr. Bob Fulford. And have you had the elective percussion course yet, or is that happening this year?
Yeah. Second year.
Have had it?
I'm trying to get a recording of this for posterity.
Okay.
60 years from now.
Yeah, but what's the problem?
The camera is the camera. It's got the back of your head. Maybe if you sat there.
The back of my head is just as memorable as the front of my head.
It might be the best shot.
You want my best side?
Stage, but if you don't want to be on the stage, then over here would be.
Well, I'm looking at the group. I mean, I could, with the group. Well, here we go. We'll just give you the side of my head.
Or sit there. Let him know.
We can go.
Yeah, we can sit over there. You can sit.
What do we want to do, Rich?
I can.
Well, it looks to me like you got the side of my head.
If we shoot, we're getting the back of your head. If that's, I mean, it's up to you.
Well, and we're going to move. I'm sorry, but we're going to move around.
Just giving you the options.
I'm not an employee anymore, you know.
Or like I could tell you what to do before.
Okay. So what I was saying was the oscillatory release stuff grew out of the work of Bob Fulford, and the reason I say grew out of that is that when we go to school, when we apply, we say, oh yeah, osteopathy, body, mind, spirit, rah, 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 and all that. So we say all the right words to get into school. But those three phrases are really difficult to link together in a substantive, effective, professional way. My own peculiar background included a theology background, a mechanical engineering background, some psych and social work, et cetera, et cetera. And so the body, mind, spirit thing was actually part of what hooked me into the osteopathic profession, not as a phrase, but as a part of my own personal quest to sort of synthesize things and put together things existentially. And I met this fellow, Bob Fulford, at a AAO convocation. And the way things happened, I mean, he was talking a lot of elements in a very odd way, but a lot of elements I had been trying to grasp and trying to link together for an awful long time. So as things happened, though, I came to his workshop he gave, actually, in this very school, another part of the building, in about 88 and 89. Had a desire to follow up and learn more, and even though he lived only about 40 miles from me in Ohio, he was sort of a reserved kind of a man, and I was sort of a shy kind of a person at the time, and so that 40-mile divide was hard to get across, until somebody had invited him to speak in Detroit. And he was getting old enough that he didn't want to drive a lot, but he really didn't like flying. So somebody said, hey, you live near him, can you give him a ride? So I gave him a ride. It was great. It was like a 6-hour tutorial. But during the tutorial, we bonded. And in the end, I helped him with a problem, just like he helped me with a problem. And the problem I helped him with was his wife was going through post-stroke dementia, was getting too much to take care of at home, and he needed a placement. And he was heartbroken over the whole thing. But I said, I know a small home. It's very small, not sophisticated, but the care is very good because it's immediate. Nothing gets missed. Everybody's on top of everything all the time. And by the way, I happen to be the doc for the home. But anyway, so through that association for about 8 years, we were rather closely connected. And when he died, how to say this? Oh hell, we're beyond the era of political correctness, aren't we? Yeah, we sure are. Anyway, I knew there were a lot of people in the profession that would trash his stuff and take it and publish it, but skew it their way so that it supported their position, but it really didn't represent Bob. So I tried to, so I took on myself reading all his stuff and synthesizing it and trying to put that into a book. But then as I started to work with the percussion vibrator, sometimes the vibrator, I had an office, I had 3 exam rooms, sometimes it'd be in the other room. And I didn't want it, I was too poor to afford 3 pieces of equipment. So, I started to say, okay, gosh, man, you got tension in that anterior part of your arm. I mean, gosh, man, it's idiasis membrane. Maybe, and it just seemed like the right thing to do was to start oscillating and start, the vibrator worked. Why did it work? And the reason I mention all this connectivity is, the reason I came into academia was that as I got further along, I started to think, he's a wonderful guy. He's a miracle worker in a way, sort of. No, not really. But I mean, he's a very clever, sincere, effective physician. But he's teaching in an esoteric model that doesn't seem to be easily bridgeable to contemporary physiology and neurophysiology. And I thought, wait a minute, there must be a way of doing that. And that's to a large extent why I got into teaching to begin with. Also, I used to always hang out with students at convocation and such, just trying to convince more people that the osteopathic stuff that we do with our hands and diagnosis and treatment is really valuable stuff. So anyway, okay, let's go to slides. No, not that. There we go. All right. So, what would I use as a shout out? I want to raise questions tonight for sure. What kind of osteopath do you want to be? What kind of physician do you want to be? A robot, an employee, an individualistic thinker, an artist, a hero? What type do you want to be? School sort of drags you out of the place where you were when you applied. Where are you going to end up by the time your residency's done? If you always think within the box, you turn into a styrofoam peanut. Who said that? Do you know? Anybody know?
Commeaux.
Me. And I'm dating myself because we don't use styrofoam peanuts anymore, but my vernacular includes a lot of archaic sayings because I'm an old guy. Diagnosis. I mean, our clinical, all the things we're doing in your studies right now are about letting you be a scientifically based, creative, insightful diagnostician. That's our role in medicine. And we deal with the patient's symptoms, symptomatology. All right. Golly, man, is diagnosis all about assessing objective criteria? Is a symptom the reflection of the physical state of an individual solely? Well, it occurs to me that the subjective side of what we do is the elephant in the room. Often we don't talk about it. And I just want to lay that theme out here now. We'll deal with that a little bit later, but I want that to be a background to as far as some of what we're doing this evening. What do we treat? What do we treat? And for years, what I had started to develop was this idea that besides somatic dysfunction, a patient comes in, they have back pain. And we look for, ERS left L4, or we look, et cetera. We have a way of defining what the problem is. But an awful lot of what brings people into an office is subjective. I don't like what's going on with my body right now. Pain is not the same thing as nociception. What is the difference? So there's a real, if you get into clinical practice very much more than 3 months, you'll realize that an awful lot of what you're doing is treating what people are dissatisfied about in their lives. And so developing that as a part of our practice is not a waste of time. And, but Fulford used to talk about this less defined aspect of health and disease as energy medicine. And he used a whole lot of sources that would substantiate that way of expressing things. And there's a vast literature that talks about energetic medicine. But what is energetic medicine? Energy. All we're talking about is the less tangible parts of the way I function, the less tangible parts of the way the patient's presenting, and the less tangible parts of how we interact. Things that don't fit simple Newtonian, this object hits that object model. But hey, I mean, I could go off. I got to be careful about going off, because what I'm used to doing is doing 2 to 3 day workshops. So we've got to just stick with some certain pieces. But Fulford would talk about addressing the emotional part of trauma, the emotional part of health and wellness, but he used energy terminology. And he used the percussion vibrator. This is really curious. The diagram there is something that kind of looks like our percussion vibrator with a little hammer thing down here and a supply tube coming into this. Well, actually, this is a pneumatic vibrator. This is published in 1912. There are articles in the early osteopathic journals discrediting the use of a vibrator because it just didn't fit into traditional osteopathic principles. What I'm saying is that these arguments about how we work, what's efficient, what's effective in interacting with a person, is an old argument. And Fulford just sort of like made it resurface in an osteopathic context. Another kind of an interesting quote I ran across quite a while back. We have recently discovered that shaking and vibrating administered by the hands quickens, stimulates, and strengthens. In reducing inflammation and congestion, it diminishes pain, and if applied over certain nerve centers, it increases the secretion of glands. Any idea who said that or when? It's Elmer Barber. The first book ever published on osteopathy, as far as a textbook, still never did that, in 1898. So again, some of these ideas, nothing new under the sun. How do we integrate them today? So Elmer Barber was kind of all right. Yeah, let's wrestle with the issue of political correctness again. What is osteopathy? Well, when we're in school, we have to come to a consensus about what we're going to teach, why we're going to teach it, what won't hurt our patients, what we won't get sued for, a variety of issues other than how we function and what works. So when I used the silly comment earlier about thinking in the box or out of the box, who defines the box? Each of us as practitioners have a real, you got to make it your own. You got to make what you're learning your own. None of us are going to practice in the same exact way, no matter what our specialty is. And so what Fulford did for me was to reinforce me to kind of remember what I thought I was about pursuing a medical career, how it fit my life goals, how it would help me out. Now, the reason I'm saying that is that, for example, Barber existed in a climate where osteopathy, even early on, was being used partly for its scientific merit, partly trying to be scientifically correct, but in that era also there were a lot of people just trying to use it to their own advantage. Barber's textbook was kind of a republication of his own course notes. Maybe he was doing it for the money. Do you know, by the time, we were talking about this the other day, has anybody been to Kirksville, Missouri? Okay, not too many of us. How big do you think Kirksville, Missouri is?
Bigger than Lewisburg, but small.
You think it's bigger than Lewisburg?
Population, yes.
Is it? Okay. I actually conceptualize it as smaller than Lewisburg, but I haven't been there too many times. It's not there's not a hell of a lot of difference. Put it that way.
Stoplights, less traffic.
Yeah, it's not a big place, but by the time we got to 1920 or 22 or so, there were three colleges of osteopathic medicine in Kirksville, all out of this self-interest type of thing. So anyway, pick and choose what you believe and try to figure out what's useful to you in your own course in medicine. So this oscillation stuff, where does it fit in terms of mechanisms of action in an osteopathic context? So let's get a little more scientific and less existential here. Do we know what hysteresis is? The shortening of muscle fibers in reaction to trauma or strain. So what does keep a thoracic vertebra, type 2, rotated to the left? Is it muscle tension? Is it all just articular jamming? Joints really float in soft tissue and muscle, so probably muscle has a big deal, a big bit to play. When we get it, and so some of what we do when we do OMM is stretching, is reconstituting tissue to its original length, trying to reverse hysteresis, fascial drag. To some extent, there's been a couple of hypotheses, with regard to the state of the neurologic balance, the proprioceptive balance of tissue. And counterstrain and muscle energy sort of base themselves on this whole gamma gain hypothesis, et cetera, that muscles can get confused as a result of trauma or strain, and they need an occasion to reset. Some people, including E.I. Letterman, have talked about oscillation and vibration helping by conditioning tissues. And conditioning is just, in this physiologic context, is just recurrent stretch in very small increments to try to get tissue to resume its normal state. Substantively, we really haven't done any mechanisms research in osteopathic medicine since the 1970s. Since Core sort of petered out and Patterson kind of changed his emphasis, et cetera, et cetera. So for years, I had really tried to get our PhDs in our schools to kind of revisit some of these issues in a more contemporary vein. And part of the problem with the PhDs that we hire to teach in our schools is that they've all trained in MD institutions. And they constitute their lab and their life's work in following up to their doctoral dissertation, which was done in somebody else's lab. And so they essentially just replicate the work of their forebears, and very, very rarely jump in a different direction, because they'd have to find more money to make a whole lab go in a different direction. So where are we as osteopathic clinicians? We're left high and dry. We hire people that don't support us because they already have a career. And so one of the things I've modeled, but I haven't been able to test out completely, to substantiate the validity of the oscillation that we do, is this circle of ideas. So we're all familiar from our training with the concept of somatic dysfunction and the fact that it has to do with motion, restriction of motion, et cetera, et cetera. Well, curiously, if you look for the theme, which you don't usually get told about, but if you look for this theme, there's a theme in physiology broadly that many activities are recurrent. They're rhythmic. They're periodic. They're periodically recurrent. And even if we acknowledge that, we kind of just let that be part of the background. Well, yeah, isn't that curious? Isn't that interesting? But I mean, gosh, if you're looking at GABA release in the brainstem during postural balance, or you're looking at enzyme release, or you look, I mean, if I'm pointing at Dr. Bob, how did I do that? You can say, and you study in your second year neurology, that my frontal cortex makes a decision to kind of point. Signal goes down to the spinal cord, and synapse goes out to a muscle. Synapse spread and then spread through the muscle tissue, and you've got a pathway. Pathways are important, but if you took an aerial shot of 219 and 2 a.m. with an infrared camera, and then you show me that's 219, that doesn't look like 219 at 4 o'clock, or 8:30 in the morning. The traffic on the pathway is as important as the pathway. So if we really truly want to understand the functioning of the nervous system, besides the pathway and each of those gates, how do they open to make the next thing activate, what's the essential traffic in our neural system? And it too, there's a school of thought called the connectivity model in neurophysiology that talks about this rhythmicity. We'll get a little bit more into this in a minute. The concept, have we heard the word neuroplasticity? It's a concept that says nerves change their behavior, and that's what learning is. In about the 1940s, brand new stuff, Donald Hebb got to looking at the neural system, and he started to model it differently. And maybe 25% of neurophysiologists think about it this way, but that's not the way it gets presented in our textbooks. What he started to look at was that instead of just thinking pathway, he started to say that what we're calling pathways are actually made up not just of gross neurons. Even a gross neuron is made up of a bundle of individual fibers. Well, starting even in the brain, what we call brain centers of different things, the thalamus, the amygdala, the frontal cortex, et cetera, they're actually populations. So activity in his way of thinking wasn't this connecting to that, connecting to that, connecting to that, to the connecting to that. He started to look at resonant cell assemblies. What's a choir? A choir is a group of people singing notes. A song is them being in synchrony. Well, what he started to look at was that neural activity on these pathways was a group of neurons in sync and in a certain rhythm of getting back to this pointing thing, besides thinking about the pathway, for me to maintain that point, my triceps, my delts, et cetera, have to be synapse firing, repolarization, synapse firing, repolarization, synapse firing. It's a rhythmic activity. So this muscle tone is not a thing, it's a process. It's a rhythmic process. And so this changes the way maybe we look at somatic dysfunction. Maybe that muscle tone keeping this vertebra rotated is not something that just happened 2 weeks ago. It's a rhythmic process that's continuing until the plasticity in the nervous system learns a new trick. It changes its rhythm. And so that's sort of where Hebb's stuff kind of starts to go for me. So resonant phase states defined muscle tone. I just sort of elaborated that a little bit. Now, there's a thing in neurophysiology, another thing called tonic vibratory reflex. How many people ever heard of that? Nobody. We don't think it's clinically important. But if I had Dr. Tom up here, and we don't have a percussion vibrator in the room, what I usually do in workshop is I'm going to say, Tom, stand up. And you see that paper on the far bulletin board?
Yeah.
I want you to point at that and close your eyes. Now, what would happen in this artificial representation is that I'd put a percussion vibrator on his shoulder. He'd keep his eyes closed, and I'd say, Tom, tell me what just happened. And he said, well, it was a little bit of effort, but I think I kept pointing at that paper. And the reason, thank you, good actor, good. So the reason that works is that people have found that application of a percussion, of a rhythmic vibration to muscle causes several things to happen. And of between like 60 to 100 hertz, which just happens to be the frequency we use a percussion vibrator at, several things will happen. First of all, the subject will either have an involuntary motion, or they'll think they had an involuntary motion, but they kept fighting it and kept pointing. But in other words, the whole proprioceptive system that's mediated by the gamma motor neuron system we talk about in muscle memory and counter strain is absolutely confused by the swamping of this tactile afferent rhythmic input into the system. Well, gosh, if all the percussion vibrator is doing is turning somebody to mush, but they need to be turned to mush, that's great. How many of you have watched or used vibrating platforms? For a while, they were a rage for weight loss. Are we familiar with them at all? So they put somebody on a vibrating platform, and they'd say, stay on there 15 minutes a day for such and such a time, you lose a lot of weight. Well, the point is that you're on this platform, it's shaking, your whole system is confused, you're going to fall over if you don't do something, so you brace yourself. And all that tonality, that tone, it burns calories instead of, running around and burning calories that way. So, but the issue is that it still engages that same neuromuscular system and activates muscle. There's a whole lot of other stuff you could go into. So it occurred to me that the key to this, the effectiveness of decreasing muscle tone with vibration had to do with the same mechanism as this tonic vibratory reflex stuff. And if you could do it with a percussion vibrator, maybe you could interact with the musculoskeletal system or the neuromuscular skeletal system using manual oscillation. So that's just each of those little topics. If we were doing a 2-day workshop, would have a whole bunch of expansion, but we don't want to do that this evening. So it's a way of interacting directly with the functional coordinative balance of the body, treating somatic dysfunction as a dysrhythmia. All right. And if you really were interested in any of the stuff that I've written with this, the Harmonic Healing book has it in it, but my email is zcommeaux@frontier.com, brain dead easy to remember. If you followed up with me, I could make sure you got it. Okay, so in order to get into working this way, when I'm using this clinically, I don't do protocols. It's like you're integrating a principle into a whole slew of ways of interacting with the system. My base modalities, I suppose, are connective tissue release, myofascial release, muscle energy with counter strain as a backup. So I'm not just doing esoteric voodoo kind of stuff all the time, or specialty things. I do, my basic practice originally was just to do family medicine and integrate all this stuff in a timely, expeditious way. But in order to talk about this and to teach it, the oscillatory release, I had to invent some table exercises to try to help other people get on board. And so this is where this sort of starts. So the doctor in the illustration, I was going to wear the same tie tonight, but I didn't. Anyway, is starting to add oscillation to the pelvis with that distal hand. And the upper hand, you know, we got motor and listening hand in this, just like we do in a whole lot of other aspects of osteopathy. So the other hand is kind of, first of all, just going up the spine and kind of seeing what doesn't move really quite as much as it should rhythmically compared to the way everything else around it is moving. If I were well prepared for this, what I usually do when they're in the lab, when I've taught this in the past, is to have a child xylophone and boing, 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 boing. No piece of the metal is the same size. They all have a different size and tone, but there's a pattern. Well, the same thing with the spine. Every vertebra has a different function, is sort of different than the one above or below it, but there's a pattern. And so you would, just as if with the xylophone, somebody had snuck in and put a pad or a piece of paper under one of the keys, and we got a ba-ba-ba-ba-ba. Well, if you've got dysfunction in the spine, you're just going to have different motion characteristics once you instill this oscillation. So anyway, that's diagnosis. Just to get us on board, yeah, what I'd like us to do, let's pair up. Decide who's going to work with who. And we're just going to start moving our patient rhythmically, just in seeing what this feels like. So find a table mate, spread the tables, wake up first! And let's just start playing with this stuff. But you know, okay. So get ready to do that. We'll do a demo in the meantime. Who would trust me to do a demo up here? Joe, Dr. Joe, come on over. All right. So what we're going to do at first? Why don't you just lie on your belly. So I'm going to ask you first of all to just evaluate your partner in any way that you choose, and decide if there's an area that you want to think about as dysfunctional or where you'd pay more attention, okay? And then what I'd like you to do is to assess the way I'm starting to talk about. So first of all, I'm going to start my rhythmic background motion by rocking the pelvis. Everybody's going to move differently. What's the rate? Don't worry about the rate. What you're doing is doing a natural push, a natural recoil, a natural push, a natural recoil. Just get some even motion going. And then use your fingers. First of all, just see if there's any area that just feels like it has a different type of motion quality than you think it ought to have. Don't worry about experience or no experience. And pay some attention to the zone where you've already done your other diagnosis, and see if there's a correlation. Okay, so what we're doing first, we're just getting used to turning on our minds onto this concept, turning our fingers on, and just getting used to generating that type of rhythmic motion. Okay, that's the first thing. So Dr. 1, play with it for 2 or 3 minutes, do a switch. Dr. 2, play for it. If I need to give you a prompt, we'll do that. Okay?
Sure, I think.
Okay, good. Yeah, we're pretty evenly matched up. Great. And don't worry about being right or being wrong. Like I said, there's no practical associated with this. So. And like we sort of implied at the beginning, you're using principles. There's nobody to keep happy but yourself. You're just using this to kind of explore, see if the ideas are useful to you. And we'll progress in a little bit.
Pushed on it harder than me.
You're the doctor. Hit this guy on the head. Anesthetize him. Tell him to mind his own business. For now, it's your back. Anyway, don't let your patient make you anxious. That's one of the things in OMM or in medicine in general. Yeah, you gotta make sure you always, you're sensitive to your patient. You care about them, but you gotta put them in their place. Tell them to mind their own business. Let you have your own opinion. It's difficult sometimes. Especially if the patient's listen to the evening news and all the direct advertising of meds to patients, and then they've read the internet and they already know their diagnosis and they know their treatment, and they're telling you what to do.
Yeah.
The hell did I go to medical school for? Anyway. So in a way, I'm distracting you, but that's kind of good, because what you're doing is you're really just following your intuition. You don't want to think too much with this. You're just going with what you feel. You're just going with what you feel, trusting what you feel, looking for correlations. At the beginning, you're just getting used to, You're just getting used to seeing what amount of motion is meaningful for you so that you can get some information. All right. So don't get hung up in this too much. Let's switch. If you haven't switched yet, let's switch, because we're going to keep doing this for a little bit. I'm just trying to get you into the mindset of finding a rhythm, tuning into tissue texture changes rhythmically rather than statically.
Well, no, this one.
So don't forget, make some kind of assessment first before you get into oscillating. Make some sort of assessment in some other kind of way so you can cross-correlate. Because the oscillatory release thing it's not a method all to its own. It's integrated. It's part of everything else we do. Yeah, so part of what we're doing too is trying to get out of protocol. I know that, is Laurie Hartman still, has he passed on, or is he still?
No, he's still teaching.
Because he went through having that stroke or something for a good while? Or he was, for about 10, 15 years ago, he was really debilitated for a while.
Oh, was he?
Yeah. He was out of it for a few years.
I'm sure I saw his, an advert for a course.
Good. Yeah. Because we used to correspond. When I started doing this stuff, what we're talking about in the background is there are several British DOs that had picked up on all this stuff. John Martin Littlejohn had used a lot of oscillation that he saw still do, and started to think about that even in the early days of osteopathy. But my read on the British use of it in the present was it gets to be more protocol than integrated into a real specific somatic dysfunction diagnosis in the way that we typically do it. And so that's sort of why I actually stopped reading those guys for a while when I started doing this, make sure that I wasn't just stealing ideas and replicating, but trying to integrate it into. Okay, so anyway, that's just an intro to just using using the rhythmic motion and just so how we're going to use it. How are we going to use this? We're going to think about it in a few different ways, and I found it helpful to just think about from high school physics or college physics or whatever, just some principles. So the concepts that are going to be partly in the back of our mind, besides our osteopathy and our intuition, is the idea of propagating a wave in a medium. And the medium we're using, though, in this case, is tissues, living tissue. We're going to think about reflected and transmitted waves, the concept of dampening, kind of like friction, or constructive and destructive interference patterns, and the establishment of a standing wave. So the medium is the string, the boundary of the medium is at the wall, the hand is initiating by different motions a wave, propagating a wave. When a wave is in a medium and it comes to the boundary of that medium, some of the force and energy can be transmitted as a transmitted wave, or some of it will be reflected. You know, so muscles, tendons, bones, you know, we're going to translate the stuff into you know, our enlightened sense of anatomy. Dampening, so harmonic motion can be diminished over distance, sort of like friction, or, you know, if I've got a vertebra that just doesn't have the same characteristic motion as the ones above and below, and what's going on, well, I have to start thinking. What tissue am I dealing with? What could impact it? You know, what's happening here? That the force that I'm instilling here is being diminished compared to what I expect it to have. So, you know, we're thinking. Destructive and constructive interference we'll use in spinal treatment in a moment or two, but constructive interference is simply that I've got two waves in a system. They can build on each other, or for destructive interference they can compete with each other. That's the same thing. A standing wave is really the concept that the incident wave and the reflective wave are in phase so that their nodes are at the same place and there's minimum energy lost. So when I'm rocking the pelvis, or we'll move other parts of the body, what I'm starting to do as my base assessment state is to create a relatively smooth rhythm, a standing wave. All right. Waves can be longitudinal or transverse. Physics tells us that, but in our application, if we're rocking a pelvis, we're doing a, you know, as far as the spine's concerned, we're doing a transverse wave motion. If we're actually pushing on the pelvis and that tissue right there, we're making a longitudinal or compressive wave, which is essentially what the percussion vibrator does. Okay, so as I've already alluded, we're going to use, a lot of times, we're going to use a standing wave to test, or as our background pattern. We'll use interference pattern or an exaggeration of the standing wave to treat, especially in the spine. Partial dysphasic impetus to make a more localized adjustment. And always thinking, what tissues am I trying to normalize? So in working with the spine, this is the left cranial-most hand is the treatment hand. The caudal-most hand is the one creating the standing wave. What I'm actually doing is with the heel, with like the ulnar side of my hand, I'm trying to make contact with what I perceive to be tension, but tension due to a posterior transverse process. So I've got a rotated vertebra. I'm going to reach across and I'm going to be having my pressure be over that vertebral process as though I'm trying to rotate the vertebra in the direction I want it. But the force I'm using is not a full three-dimensional go to the barrier, away from the barrier, or pressing toward a barrier, but I'm using this oscillatory force as the impetus to change. All right, well, let's just do that. So, another volunteer. Anybody want to come up and be a guinea pig for 2 minutes? Get you next. Well, whatever. We can use this table for arm wrestling. All right, you guys want to arm wrestle? Okay, wait a minute. Stay put for a minute. And come on back up a little more like you're sitting on a bench. All righty. Okay, so... Oh, such a catastrophe. Glory be. Oh my God, how long have you been this way? That's a joke. So she had like a T2 was slightly left rotated. It might have been a rib posterior. And then there's a zone down here where there's just a nice smooth type 1 right rotated from about oh, T10, I mean, the L1 to maybe like, no, about T10 to, alrighty, so there's a little bit of stuff going on. Alrighty, so let me see if, oh, you tender there at all? Not really?
Not a whole lot.
A little bit. Roll in your belly. Yeah, roll in your other belly, as they say. Yeah. Okay, just relax. Put your hands at your side. Relax, relax. All right, so let's see what we've been doing so far, see how it makes sense. So, tender at all?
Yeah.
A little bit. So, okay, let me be on this side for best effect. So anyway, so there's something going on like around where, like these 7, 8. So rhythm, 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 rhythm. Take a deep breath in. And breathe out. Let me load it up to the barrier a little bit. Take another deep breath in. And breathe out. A little bit out of phase, and another deep breath in. And breathe out. So it's a mixed bag. Actually, what I said was originally we're doing these as, not as protocols, but integrated in as everything else. I have a hard time stopping and doing just one thing. But anyway, so anyway, let's just go back to the table and just practice, you know, the oscillation, finding something we want to move around a little bit, and try to figure out how much of the oscillation force, how much of a little thrust is going to get us what we want. Okay? So just get into doing some stuff.
Do you usually put a stand on the opposite side, or does it really matter?
Well,
It's like,
the opposite side works for me because,
Yeah.
I don't know, you know, when we've done this, we do this teaching of doing a cross-hand technique, and it seems like just given the width of a table, if you're leaning into someone, if I want to rotate something, if I'm doing this, you can do it.
right.
But this just feels, just lets me, you know, it's
Yeah. So you kind of
be
find
more
it,
in a
then you
flow.
kinda go on then you would move yourself.
You know, yeah, I'm just doing this as an artificial exercise. You know, when you line up what you want to change and you just figure out that oscillation is going to be a help here, you do what you do.
Okay.
In other words, in practice, I'm using oscillatory force in a lot of different contexts whenever I'm just approaching a barrier.
Sure.
But however I structurally want to approach that barrier, I just do it.
Okay.
Yeah. So you're right. You're just thinking. You know, you just got to think. That's all. What's going to work for you? Do 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 do. So all you got to do is do verbal or nonverbal negotiation with your patient. Don't worry about the practical. Your patient needs to be comfortable also with what you're doing. Got a stressed out baby, what do? We rock the baby. Rhythm's a real natural, relaxing activity. Excuse me for misintroducing you to the president. I realize I messed up your name when I... Yeah.
Andrea will work on
Again, H is still kind of covering.
Okay, so we're just trying to get a feel for this, just to see if it feels like you're at home with it, or ask yourself the question, where am I going to go with this next? Okay, so play with it a little bit and then get into switcheroo. You know, switch with your switch table rolls and treatment rolls, and just to get this is just a sampling. And I know you guys got a million things to do. They didn't give you the week off, did they?
No.
Nah.
Shouldn't recommend that though.
Yeah, I know.
They might listen to you.
Nah.
Nah? You got
That's actually the reason I don't teach here anymore. I get tired of not being listened to.
It's not you, it's me. Right? That's the best thing to hear.
Okay, so again, correlate with what you feel in other ways, what you palpate. It's an okay thing to do. And then start to think about the spine and the back and the ribs, not just as things, but as process. And you're initiating a rhythmic process, and you're looking for lag, for dysrhythmia. Things just not moving the way they should. As a composite, not as individual elements, but kind of just as a composite. And to some extent, you're trying to see if a little bit of oomph in rhythm or out of rhythm is going to help get things moving the way you want them to.
It's just like when you have PBs, you've got it like right on the right.
Right.
Hurts.
Mm-hmm.
And now Dr. Richardson has got it on like 106,000.
It looks like that's
I think we're different for every area.
Let's see.
I think different lesions need to be. Yeah. So each one, you just have to feel it and find it.
Oh, good. Great. So just play with it, see what's useful to you.
That's actually good. I can feel it.
Yeah.
Yeah, like right on it right now. I can feel it.
Do I need any help?
Not necessarily. Yeah. What I find is, you know what a flywheel is in a kind of a motor system? A larger mass, it's going to keep the motion more regular.
Yeah.
The larger part of, like if you use this pelvis instead of right here as your flywheel, as your oscillating mass, you're probably going to get better return for your push. And so I'd just move down just a little bit for that reason.
Okay.
Yeah. As you'll see, other parts of the body, sometimes, you're getting rhythmic motion, sometimes you're using the arm. You have to figure out what mass, if it's in them or in you, is going to kind of make it all smoothly rhythmic. And so, whoops, sorry about that.
That's all right.
But down here, yeah, using the full pelvis is usually a good deal.
So when people look at this video, you'll be in public somewhere, and someone will look at the back of your head and I'll go, I know that guy.
Good. That's fine.
Like, I was able to get the demonstration. Okay.
Maybe, yeah, good. Well,
Can you, if you can do me a favor, do the demonstration on this table
Okay.
and not that table. I mean,
Gotcha.
it just gives me a
Yeah,
little...
we were over here. Yeah, we can do that.
Yeah.
Okay. Well, maybe we should invent butt book.
Huh?
Maybe we should invent butt book instead of Facebook.
I'm not even sure how to respond to that.
Okay, let's come out of that. Let's come out of that. Now, I had mentioned earlier that, you know, I do these, we're doing protocols, we're not really doing treatment. And I also mentioned that muscle energy is probably might be my home base for an awful lot of manipulation. Who else would want to work for just a minute? Oh, Leslie said she wanted to work. So have a seat. I'll tell you what, Rich is trying to get us to be on camera, so why don't you sit on this side? And my go-to method for working with the back basically is to work seated, partly because if a patient's come to me and they don't really know everything that we do, they're sitting and giving me a history, and it's just really easy to make a transition. And alrighty, so where's that start and stop? Yeah, it's real localized. Yeah, is that tender at all or not really? So we've got just we're like about L3, and we've got like a left rotation, right rotation. I could do the rest of the three-dimensional diagnosis, but I usually don't. Cross your arms on your shoulder. Cross your arms on your chest for a minute. Okay, so relax. So I've got a right rotation here. Okay, boy, she trusts me. That's good. All right, it is good. So, oh, great. Something let go already. Take a deep breath in. Breathe out. Okay, so I'm going to a barrier. I'm oscillating a little bit. I'm creeping up on the barrier. Turn to the right. And relax, let go. You okay? Take another deep breath in. Breathe out. All right, so it's all around my thumb. My thumb's monitoring what's exactly happening at the segment. That's what I want to know. But oscillation is kind of worked in with everything else at the barrier. So it's not, you know, like I described when I've written this stuff up, that we're not starting a new model. We're just trying to highlight one element of force that might be useful in certain circumstances. So patient comes in with, so one of the problems you guys have when you're in OMM lab is, you know, you're told what topic to do what week, and yeah, we have to do it that way to keep everybody together, but how do you kind of put everything together? Patient comes to me and they say I've got tingling in my wrist and kind of goes toward my thumb on the side, and you know it bothers me, and you know and you know they have some degree of either carpal tunnel or maybe it's their radial nerve that's impinged instead of their median nerve. And lots of docs out there will say, okay, does that make the symptoms recur? Well, okay, well, we got to refer you for surgery. Oh my golly. Well, first of all, I've had a number of patients where they'll have a carpal tunnel release, and they come back to me and say, it's a good doctor, nice doctor, treated me well, but I still have the symptoms. Well, maybe the median nerve doesn't exist right here just going through the carpal tunnel. Maybe it has an existence all the way going back up to the, the fibers have an existence going all the way up to the to the neck. So I want to know, first of all, that I've got, obviously I would be doing the spread for the retinaculum. I'd want to articulate the thumb. I'd want to be doing a myofascial release for the arm, but I find doing it as first of all, just as putting the arm under a little tension, oscillating and doing that as myofascial release. If I torque the arm, then I'm putting the fascia under a greater degree of tension. I want to do another bit of oscillatory release. And then the other thing I can do while I'm doing this, just like I was reading tissue when I was doing the spine, I can be thinking, okay, I'm feeling that motion. I've done this a number of times. Does it feel like it should? If it doesn't feel like it should, where is that coming from? What am I reading? Is there tension in the elbow? Is there tension up here in the shoulder? And by changing vectors a little bit, I can kind of read that a little bit more. You know, she's nice and loose. Obviously, her arm's connected to her torso, so there's restriction up here. There's a little bit of crepitus in the glenohumeral joint. You know, a lot of things that we do as articulation can be done instead of one big bite. They can be done in smaller increments of recurrent mobilization. And I can creep up to a barrier. You ready? I can creep up to a barrier, and I can just oscillate at the barrier and see if the restriction will melt a bit. And meantime, my right hand is, I'm using this as my, before, when we were on the pelvis, I brought up the issue with someone at a table that when you're doing this, you're sort of using the pelvis as a flywheel. You know what a flywheel is in a mechanical system? We have a larger wheel, a wheel that gets going, and once it gets going, its momentum smooths out the motion for the rest of the system. Cars, they might still have them, I don't know. Things have changed. In any case, in this situation, the whole arm is like a flywheel for me as I'm moving, and I'm able to use my monitoring finger, let go, just to see what's going on with the rhomboids, the serratus posterior, anterior, levator scapulae, et cetera, and almost all of us have tension there in our levator scapulae insertion, so I can. I'm talking out loud what I'm doing because none of this is protocol, most of it. I mean, it's just that I do know when I have a patient with neurologic symptoms in the arm, I want to treat the whole arm. I don't want to pay attention to just where it hurts. Okay. Lay on your back for a moment if you would. Same thing. Person has an omenitch here, or there's something else going on there in their lower extremity. I can do the same thing. I can integrate oscillation as another element of diagnostic force or treatment force to so I can read an extremity this way. I can use the leg as a flywheel, and I can kind of put a little bit of rhythmic motion through it. And the question I have in my mind is there restriction, and where is it? There's a little bit of restriction, like in this zone. I can just feel like the stuckness is this far away rather than that far away. So rhythmic motion can be used diagnostically, and like I said, it can be used from a treatment standpoint. Okay, why don't you sit up? So, as I said, typically, if I were really developing this as a methodology, we'd be working for a minimum of a day or a day and a half, which we're not going to do this evening. So let's make a transition. Rich, let's go back to slides. At the beginning, we were talking, I brought up the objective-subjective idea and the fact that, now I'm paranoid. Where does he want me to sit? So if we were doing a workshop, wait a minute. Earlier I talked about the fact that there's the objective way of proceeding medically, but where does subjectivity fit into our practice? And Fulford used to talk a lot about managing your attention and managing your intention in diagnosing and treating, and I used to think, what does he mean by that? And I used to think maybe he was using the same word, but then I realized he wasn't. Because both your attention and your intention, besides your physical behavior, can be an important part of engaging a patient. Some patients are not easy to figure out. And they just don't have conditions that seem to be defined biochemically or according to an easy algorithm. And you know, in medicine we use the term psychosomatic illness sometimes with regard to the patient. But then with our own behavior as physicians, the only time we allude to the subjective aspect of our engagement with the patient is when we use the term bedside manner. And you know, we kind of say, yeah, bedside manner is important, but being smart is more important, and we kind of put the bedside manner stuff in the back, in the back of the room. I would contend that the subjective element of both the presentation of the patient and the refinement of our own behavior is much more fundamental than we typically think about it. If you have a musculoskeletal practice, or even if you have a whole lot of different types of medical practice, one of the main things that's going to present to you is either the symptom of pain or another symptom with a heavy emotional component. Even if it is just somebody saying, what is this? Is this really cancer? How long is this going to last? Is this going to ruin my ball game or my life? So there's very often an emotional component to a patient's situation. So what do we treat? Do we just take care of the stuff that shows up on lab tests and x-rays and let the rest of the stuff just go and say, well, I hope the patient does okay? For me, the reason I brought up Alan Shore's name was he was cited by a couple of docs who were here for Osteopathic Week about 3 years ago, who were talking about spirituality and medicine. And Shore is a psychiatrist. He's a neuropsychiatrist, and what he did in his life's work was he was trying to work up a justification for the process of transference in psychotherapy. And if you haven't gotten into that literature, transference is just to say that a practitioner, on a subliminal level, the patient puts on the practitioner a different role, like of a parent or a sexual partner or something, because of their need to work out a conflict that they had with that other party. What Shore spent some time with this was he realized that our emotional reaction to a lot of situations, including what I think of when I think about pain, has to do with the hard wiring of the patient and how let's go back to the slide for a minute there, Rich. What he was calling this fronto-orbital thalamic column. So this is a hardwired system, especially in the right non-analytic part of our brain, which behaviorally connects our seeing part with our thinking part, with our brainstem, with our emotional, our thalamus is our emotional part. And what he's making the case for, and a number of people agree, is that when I'm the baby being rocked, and I don't know nothing from nothing except that my mama's going to protect me from everything coming down the pike, I'm being rocked and I'm being breastfed or fed, and I'm looking up at mama. And that eye contact with her is telling me things are going to be all right. Relax, I'll take care of you. And then what that eye contact does with me as the baby is that it starts to make me have a certain structural connectivity between the eye that sees threat, the frontal lobe that wants to figure out what to do with threat or discomfort, and my emotional response to threat. And this whole system is hardwired then and developed for me in my developing brain in my first 2 years of life. And then that equipment for dealing with stress and trauma and threat or pain or all the negative aspects of life from the environment is mediated by that system. And so, I mean, I may have somebody hit their ankle with a hammer and say, oh crap, I lost two minutes, I'll rub my ankle, I'll lose 2 minutes at this job and I'll have to go back to it. But then I have somebody else that says, oh, my ankle, I gotta go to the emergency room, right? So people deal with stress or even pain in a very different way, and it has to do with this hard wiring that we've had with our primary caregiver at the very beginning. Well, somebody comes to me with back pain. Is back pain all the same thing? Is it all just somatic dysfunction? Is it all just a sacral torsion or an anterior innominate? Well, all those things may be the case, and I may have a protocol for figuring out how to deal with them. But the other element is, maybe in our OMM context, the stuff that Shore was talking about relevant to psychotherapy is real relevant to me working at table with my patient. I'm not done until I've treated their somatic dysfunction. And what else? Slide number 7. No, I'm kidding you. Their somatic dissatisfaction. We're not done here until they're a happy camper. Otherwise, they're going to cuss you out, or they're going to go to somebody else, or they're going to be back, or they're going to whine and carry on. You're not done until you're done. And why am I even bringing this up in the OMM context? Lay in your belly again. One of the things I'll do with a patient in a variety of contexts is to finish, well, first of all, let me not talk about it. Yeah, let me talk about this as a finish. But, so you see what I'm doing. You know what I'm doing now. Okay, so you came in with this back pain, and we gave you this diagnosis. We gave you an explanation, and we told you how long it'll last, probably based on what I've seen a million times. And so, okay, this is what I want to do as home exercise, and I want you to do this, and I'm pretty confident we're going to get so what am I doing? I'm first of all talking to the patient in a way that's going to try to separate them from their anxiety over this problem. Am I deluding them? No, my experiences tell me I'm telling them the right thing. But what's my voice tone doing? My voice tone is also sort of trying to help them to dissociate the same way you would do if you were doing hypnosis. So you're sort of trying to get that separation between the patient and this thing they think they're going to be stuck with forever. Because realistically, they're not most of the time anyway, unless it's a metastatic cancer. But how many times is that what brings a patient in? Not many. All righty. And then as I'm rocking, what I'm doing here as I finish is to, I might spend 2 or 3 minutes doing this. And then since we're in like a class setting, it's not going to go the same way as smoothly. But I'm progressively just talking to the patient. And I may not even need to talk to them after we've made the point that we're trying to help them dissociate and help them relax. And successively, I'm diminishing the amplitude of my rocking. They're getting used to my hand going up and down and doing a pattern. But the lesser amplitude and the lighter pressure in a pattern finishes my OMM treatment so that the patient is not spastic worried, but they're reassured, but they're also physically dealt with in a way that's kind of going to deal with their emotional side besides just dealing with the objective analysis of their symptoms and the objective correction of what you think you need to do from a procedural way. So, okay, good. And then I tell somebody they can lie there as long as they want. They can, a couple minutes and relax and such. So, now what's implicit in what I just did is you got to feel confident about what you're doing. And you got to care enough to take that little bit, to do that little bit extra. Instead of, first of all, med school makes you a raving neurotic, right? In terms of performing. Do you think that gets any better in residency? Hell no. You'll be such a case of scrambled eggs by the time you get done your residency. You're going to have to reclaim yourself as a person. Really? So what I'd like to do right now is to let us just do a little bit of an inventory. And this to me would really be part of OMM. So, personal inventory. Where's your heart? Where are you in developing your own depth as a person? Where's your spiritual orientation? I'm not asking you if you go to church or not. I'm saying I don't care if you're paying attention to to Allah, to Buddha, to a Zen master, to Jesus, to whatever. Where are you in your own spiritual development? Back to slides there, Rich. I'm not as important as the content. Okay. Where's your ethic regarding compassion for your patient? We've been through this generational transition where you guys are mostly going to be employees. And income and job security is important. But I don't think we do a job fully medically unless we maintain that compassion element. I mean, we just don't have good outcomes when we just follow a physical or objective algorithm. Where are your hands? If you're doing OMM in lab all the time, you're always worried about doing it correctly. When you're doing practicals, did I remember the recheck? Et cetera, et cetera. If you're doing OMM, you got to get loose. Let's think about doing OMM. Just everybody stand up right now. Pretend you're going to go to the table and you're going to do OMM. What do? All right, you're in your head. You're in your head. Am I going to find it? Am I going to do it right? Well, the first thing to do OMM is to get loose. Bend your knees a little bit. Let yourself be loose. And get a mantra. Don't worry, be happy. So all this is like part of self-development to get to the table. And what I like about the rhythmic thing, the oscillatory release, is besides the physiological conceptualization of how it may interact with muscle, it feels good. It's dancing with your patient. People come in, they got bad news, things going on, and I understand that. I've been there. But at the same time, rocking a baby, autistics rock, rhythm is just a natural, nice state of being. So this oscillatory release, I think, is on target clinically. Let's go back to slides and see if there's anything else we've got to do to wrap up. I don't think there is. Oh, I was going to say back to the table and do some OMM, but we've had enough fun for tonight. Realistically, what I wanted to do tonight was really just open a door, let you sort of expand your horizon a little bit about what OMM can be about. John and I have talked different times. You go, what is osteopathic practice? What's osteopathic practice in the UK? What is it here? We could talk about how different it is. What is it in France? What is it in Germany? What is it in Italy? What is it in Finland? What is it in Japan? What is it in Australia? What is it in Brazil? It's all different. But it has to do with certain principles that we have in common, but that horizon's not close. It's way out there. Likewise, when I was looking at door pictures, I realized, you go through one door, you're not done. Lots of doors. So anyway. Well, listen, thanks for your attention. Thanks for coming out, and be well. Yeah, exactly. Want to do any follow-up later? Anybody have? I didn't. My last. Let's go back to slides. Yeah, my last click was comments, questions. Anybody want to ask anything or bring up anything from experience?
John and I were talking just briefly here, and we practice differently in a different continent and stuff, but we find both of us have done oscillatory stuff, just intuitively. No other reason you're trying to work a first rib or you got a counter strain point or something just seems right to readjust it all. So there is that thing, and it is when you talk about the baby. I have 2 grandchildren right now that I've had little ones for a long time, but 6 months apart, and now all day long I'm doing this whether I have a baby here or not. There is that piece. And old folks in rocking chairs.
Yep.
This whole vibratory and oscillatory thing is an intuitive piece, and if you feel like shaking it a little as you come out of a counter strain point, or if you're trying to get a first rib for whatever reason. So it is intuitive, and we both had that experience, and not that anybody ever really said, oh yeah, be sure to have this for.
Exactly. Thanks.
Where you want that oscillatory auditory motion to go? Do you want it close? Do you want it far away? I mean, just play with it, how the tissues feel when you're.
Yeah, when I used to do lectures here, one of the things I would use as part of the way of talking about treating somatic dysfunction is to always think about what your target tissue is. What tissue is distressed, and then think about what its characteristics are, what it likes, what it needs. And I mean, what you're saying is the same thing. It's to say that in this context, does that tissue need something abrupt, or does it need something really delicate? I mean, I'll use oscillation if I'm doing cranial and doing a V-spread, and I'm doing something like that, and I just, you just get in a little tremor, or that's actually how I use it with the cervical spine. Cervical spine, I'll be grasping the occiput. The first thing I do when I'm treating anybody's neck is to do traction. So I'll do some traction, and then I'll figure out with my thumb where the apex of a bend is. It needs a little bit of attention, and I'll just articulate around there. I'll do a little bit of oscillation. I'll articulate and go a little bit more toward a barrier. Then I'll ask my patient to push away from the barrier muscle energy, and then maybe if it needs a little nudge, we'll do a nudge. But yeah, there's nothing magic about the oscillation. It's just another application of force at the right place at the right time, especially trying to fine-tune something. Exactly. So yeah, you're saying, are you telling these students to trust what they feel? Is that what you're telling them? Great. Good. Exactly. Well, thanks.